And they do the evaluations online.
Okay.
They do the evaluations online
For
for today.
oh,
Or their pieces of paper.
they have these guys. Yes, they have paper, but they also, for CME credit for physicians, they'll have to call into a certain number. I'll make that announcement, but I don't know about the other.
I can make the announcement.
Okay.
Um,
Because they have these paper forms out front.
oh, they do?
Yeah. So
Okay.
hopefully, everybody pick one out. Hopefully
Okay.
they remind them. I'll make sure they do.
Because that's the most important.
Yeah,
You'll
sure.
just like both of those right there.
Okay.
The green and the white one. That's all I need to be reminded. taping this. Tim Becker was good. All right. Good afternoon. My name is Betty Shields, and I'm with the Kent School of Social Work at the university. I'm the director of the Ohio Valley Appalachian Region Geriatric Education Center, which is sponsoring this presentation. And I'm also the director of the Kentucky Person Centered Care Program. It is our pleasure as the Geriatric Education Center to wrap up 18 years of funding from HRSA by ending our tenure in the existence of geriatric education centers with this presentation this afternoon related to Alzheimer's disease and related dementia and chronic illness. We have two speakers this afternoon who both are very talented, have great experience, and have a lot to contribute. And I'm delighted that they agreed to be part of this presentation. Gopalraj is assistant professor in family and geriatric medicine, as well as has an appointment as an associate in the palliative medicine program. Sharon Mattingly is a recent contribution and addition to the family and geriatric medicine unit, as well as the clinic. Sharon comes from lots of experience in geriatric medicine, as well as geriatrics, is a licensed clinical social worker, and has had years of experience in long-term care as well. We want to please request 2 items from you this afternoon, as our funders require it. You all know the drill. One is the green form, which is the registration form, and this gives some profile information to HRSA. They do not capture your social security information, and we don't track your personal information for long periods of time, but HRSA requires that form, as well as the evaluation. And hopefully many of you picked up a 2-page handout at the front table that is basically the agenda with your learning objectives, and page 2 is the evaluation that accompanies that. So we request that you please complete the evaluation. You can either drop it on the table or you can leave it in your chairs. We'll be checking afterwards. Ideally, you drop it off at the table outside. So with that, I give you Dr. Raj.
Thank you, Betty. All right, quick sound check. Can everybody hear me okay? All right. Well, I see some very familiar faces and lots of new ones too. Now, this presentation, I'm told, it's about an hour. I have a bunch of slides, but the main goal is to have a good conversation about some difficult patient situations you might have encountered. And by the end of this presentation, you'll realize there's a lot of questions surrounding this topic. And unfortunately, we might not have all the answers, though we definitely try to move the science forward in terms of how to take care of older adults with dementia with other comorbidities. Okay. And please speak up and interrupt with questions as we go along, because we do want this to be a lively conversation. And from what I understand, I'm told among the audience we have not just physicians, but also we have other disciplines that are presented, and maybe even some patients or caregivers. So I've tried to keep a balance between how technical the discussion needs to be. But we can go into details more if you have specific questions. All right, and I'm delighted to work with Sharon, and from time to time, she'll be a good resource sharing some aspects of patient and family interaction that will especially be important in taking care of the individual as a whole. Now, a quick overview of the learning objectives, and we would go through dementia, what it means, and also I will point out to resources along the way, and just a general announcement. If you have specific questions or you would like to get additional resources by email, we would leave a sign-in sheet up front, and you could leave your email, and I'd be glad to send in some additional resources focused on specific areas. And we'll look into the impact of chronic diseases on dementia, and then the touchy topic of, how do you go about making decisions, or when do you start the process? Does life expectancy play a role in it, or how do you use that? And also the nebulous question about quality of life and how that shapes things up. Now, we do have some links to some videos. We may not watch all of them, but we'd watch portions of them to get a gist of some of the issues we deal with. Quick show of hands, how many of you have never seen a patient with dementia or never had any interaction with them? Okay, so I guess we don't have any medical students who are fairly early in the process. And so this video is going to talk about an experience of one family member describing how dementia impacted their life.
I'm lucky, really, because I was lover to one of the most beautiful women in the world. What man would want that? She is physically beautiful. The very first time I ever saw her, it was like looking at Grace Kelly. But I've gone from being her lover to her carer. I've always been in control of my life as a journalist, as a reporter, as a newscaster. I knew what was happening, and I was in control. Suddenly, I'm not in control anymore. This is happening despite me, and it makes me angry. Bond is contented. I go to see her, and she's in a care home. She's now been in for 6 or 7 months. She's never once asked me where she is, why she's there, where have I been, what have I been up to, all the sort of things a normal wife would ask. No questions at all. She is contented. I'm not. I know. I remember what she's forgotten. I still have the memories that she's now lost. So dementia can get the carer too. You find yourself grieving. You're mourning. You're going through the grieving process for someone who is still alive. If I'm with her in the care home, and I whiz off to talk to one of the carers, when I come back, she greets me as if she hasn't seen me for days. I took the best. Just the most wonderful, wonderful holiday ever. And the illness had already begun. But she loved it, and now she doesn't remember anything.
Kind of recounts how dementia affects not just the patient, but the caregiver and the family as a whole. Now this slide shows that memory can change as we age. And if you notice the curves, even though aging is associated with some memory impairment, it doesn't progress to the level that we see with dementia, which is due to an underlying pathology. And even with dementia, if you follow the curve, quite often we end up diagnosing patients quite late in the process. So even though they are on a different trajectory many years earlier, Unfortunately, our techniques or ability to find them were limited in the past. And as time goes on and research advances, we are getting better at trying to diagnose people earlier, even when they are asymptomatic. However, some of those still are not widely available, or they are still under research settings where we can do certain tests to figure that out. Now, this video is going to go over some of the 10 early signs and symptoms that we see, and they compare and contrast with what do we see with aging, which is normal, versus what we consider abnormal. And this is based on information from the Alzheimer's Association website, which would be a very good resource for anybody interested in this area.
Hello and welcome to Your Healthy Journey. Today we'd like to bring you a quick video on the 10 early signs and symptoms of Alzheimer's. Number 1 is memory loss that may disrupt daily life. And below I'm going to be reading off what's typical age-related change also. What's here is sometimes forgetting names or appointments but remembering them later. Number 2, challenges in planning or solving problems, and making occasional errors when balancing a checkbook. Number 3, difficulty when completing familiar tasks at home, at work, or at leisure. And the typical age-related change would be occasionally needing help to use settings on a microwave or to record a television show. Number 4, confusion with time or place. Age-related change could be getting confused about the day of the week, but figuring it out later. Number 5, trouble understanding visual images and spatial relationships. And a typical age-related change would be vision changes related to cataracts. Number 6, new problems with words and speaking or writing. And an age-related change would be sometimes having trouble finding the right word. Number 7, misplacing things and losing the ability to retrace steps. And a typical age-related change would be misplacing things from time to time and retracing steps to find them. Number 8, decreased or poor judgment. What's typical age-related change? Making a bad decision once in a while. Number 9, withdrawal from work or social activities. Sometimes feeling weary at work, family, and social obligations. And number 10, changes in mood and personality. And a typical age-related change would be developing very specific ways of doing things and becoming irritable when a routine is disrupted. And those are our top 10 things to look for early signs of Alzheimer's. So if you have any of these, please get a checkup promptly, because the sooner you find things out, the better off you'll be. So thanks again for coming and stopping at Your Healthy Journey, and we look forward to giving you more quality information in the future. Thanks. Have a great day.
At any point, if you have more questions, you can raise your hand and we can stop.
Alzheimer's disease, the top 10 preventive strategies. I'm Dr. James Machino. You know, only about 2% of Alzheimer's disease.
Okay. Now, dementia is any condition that's going to lead to severe memory loss. Now, it's generally defined as a group of brain disorders which can lead to deterioration of intellectual and or social skills, severe enough to interfere with day-to-day functioning. And the simple thing to remember is dementia is like fever. So fever could be from many different reasons. So nobody will get a diagnosis of fever without saying why exactly they are febrile. And so the same applies to dementia. So getting an accurate diagnosis is a very important task. Now, if you look at it, there are many different causes. I've put up some of the more common causes. So the most common cause as we grow older is Alzheimer's. And based on the literature, it ranges anywhere from 50 to 80% of patients. And the next common one is vascular dementia, which could happen after somebody has a stroke, for instance. Then there are other illnesses such as dementia with Lewy bodies and frontotemporal dementia. Now, in our talk today, we are going to focus more on dementia related to Alzheimer's disease. But the problems presented with dementia is fairly universal and is probably applicable to any of those. Now, when we talk about Alzheimer's, again, I have a lot of information on these slides, but we might, depending on the time, we may focus on some more than others. And age-wise, usually it's a disease of older age. When you look at the population more than 65, on average, about 10% of the patients living in the community might have this illness, whether we have diagnosed it or not. Now, as we grow older, every passing decade, the incidence fairly doubles. So by the time somebody is 85, there's a 50-50 chance that they're going to have some form of dementia. But the other take-home message I want you to have is, just because we grow older, forgetfulness is not inevitable. So there are patients who live even beyond 100 who never have dementia. And so in fact, if you're able to escape it long enough due to your good genes or lifestyle or other reasons, you are able to stave off dementia. In fact, there's a lot of literature or research efforts into the contribution of lifestyles or other modalities, and which we'll point out later in the talk. And usually it afflicts females more than males. And the mean duration from the time of diagnosis, based on the literature, maybe about 7 to 8 years on average. But that is very variable. So we have patients who might progress very rapidly within 2 years or very slowly over a period of 20 years. And so it's very difficult when you see a patient for the first time in the office to exactly figure out which trajectory they're going to be on. So it might involve spending more time with them, and longitudinally you might be able to make better prognosis based on how they do. There are definitely some genetic mutations that put you at higher risk, and with passing time, more and more genes get looked at, and we have plenty of association studies, but very few genes that seem to make a big difference. One of the early ones we talk about a lot is ApoE, but even there, it's very interesting how science advances as to what's the prevailing theory as to what causes Alzheimer's. Does ApoE play a big role, or does the role of the amyloid peptide protein really key to this? And in fact, there was a very good write-up in Nature recently about that, and I'd be happy to email that information, because I think it's a good read even for a non-medical person to catch up with the science behind Alzheimer's and what the current thoughts are. Now, quickly, diagnostic features, memory, obviously we are going to have some trouble with that. But in addition to that, we would have one or more of the following. Again, these are big words, but I'll try to put in some of the meanings that go with that. So people might have problems with communication. People might have problems with their motor movement. Even though their nerves function well, they cannot make certain movements, or they have difficulties with certain activities. They may have trouble recognizing face or familiar objects. So you could ask them in the office, hold up, okay, what is this? And they may have a hard time describing it, or they make up words for it. Executive planning could be impaired. So even a simple act of ordering a pizza might become a very big chore, because we don't recognize how much planning it involves even if it's finding a number, making the call, ordering a pizza, knowing what you want, and having the money to pay for it when they show up. It involves several different distinct skills, and so that is impaired over time. And it has to represent a big decline from the previous levels of functioning, and definitely lead to interfering with social and occupational functioning. And usually with Alzheimer's, we're talking about a slow progression over time, and no other obvious etiology when you look for with all the tests that you know how to do. Now, this kind of talks about the Nature article, and but this image is pretty telling. On the one side, there is a picture of the normal brain and how it looks. But if you look towards your left, they show that there's shrinkage of the brain overall. And it's pretty dramatic to see such images. And now, we have another video, and I would hand over to Sharon to add in her insights. Oops.
The video is going to show caregivers' perception of what it's like to live with someone and take care of someone and watch them change over the course of the disease.
I met him November 24, 1942. He was handsome and tanned, tall. Oh, his name was Sharon. I said, that's a beautiful name. I've been looking for peace all my life. And after 3 days, it closed. He was sincere, he was honest, he was sweet, he was been steadfast, always a gentleman. Now, he's become a little bit irritable, unpredictable, sometimes unkind, but it is not the mark of then. A good 18 months ago, he became so difficult to manage. Things became so bad in the house. Papers were lost, bills were not getting paid, bills were being paid twice. So we went to see a neurologist, and he put Mark through a series of tests. And his opinion was, first, that it was cognitive impairment, and then after some of the scans, then it was early Alzheimer's disease. I was devastated because I didn't know a lot about it, but I did know that it's a mind-destroying disease. I know that it has a progression, the outcome of which is too distressing to contemplate. And this is so tough because you don't know just from day to day how it's going to be. We're going through a good patch right now, and I have learned a great deal. But it isn't easy. And sometimes the things that are said are hurtful. But you have to realize it isn't the man I had. It isn't the man I knew. It's another person. It's someone taken. It's this cruel, cruel disease that is taking over the mind of the man that you knew. But with God's help, I'll cope. And all of these people out there that have to face this tremendous challenge, they have to pray for strength and good health and common sense and reality and deal with it. And they'll get through. They'll get through just fine.
And again, some of these videos are to jog your memory in terms of your interactions with a patient or a family going through this process. And talking about real-world patients, okay, I need to figure out. So this is a patient whose experience may not be the most unique, but I'll share with you. Recently, I saw a 70-year-old male with several medical issues, but his biggest problem was his memory due to dementia, Alzheimer's. He also had problems with some hypertension, but some issues with pain, with history of spinal stenosis. And he did not do, but a lot of the talking was done by his wife, who was very concerned, and she came with him to our office. And when we saw him for the first time as a group, it was over a crisis situation. And he was actually part of a research study at the Sanders Branch Center on Aging at UK for several years, and he was still following Dr. Jaiga over there. And so I'd let Sharon talk about some aspects, some of the stuff that was shared at that time, and as we navigate this process.
His wife had talked about the pain and back from the consequences. They had been to surgeon about 2 years ago initially to get an epidural shot for the pain. At that time, he wasn't able to tell the surgeon about the pain, and it was successful. It lasted for about a year, maybe a little more. And then last fall, his wife started to notice that he wasn't walking the same. He was doing the same. He was sitting a lot more, not wanting to move. Unfortunately, as he was progressed, his communication had declined, and he was no longer able to say, I'm in pain. So she was watching for the nonverbal signs, and she took him back to the surgeon, who said, I'm willing to give him the shots again, but only when he asks for them. And she said, he can't ask for them. And the surgeon said, believe me, he will beg you for the shots when he needs them. So she left her very frustrated, and came to us and said, how could another professional who should know about Alzheimer's think that he could ask for help when he can barely put a sentence together, really can't put a sentence together? How's he going to beg him for help? He should know to look for the nonverbal signs. He should know to ask me, his wife, who knows him best, who lives with him 24/7. He should trust me when I say he's in pain. I watch for the signs. My daughter watches for the signs. He needs an injection. And so she asked Dr. Rangaraj to call the surgeon and say, this man can't ask for help. This is his disease process. He's not communicative, barely. He can say hello, thank you. You look nice today. He can say to you. He's polite, but he cannot carry on a conversation. When you look at him, he's very blank in the eyes. He repeats himself on my own thing, and he would say that 5 times. Yet he would have trouble sitting up, groaning a little bit. At home, when I went to his home to talk with them, and he was untouched the whole time I was there because he couldn't move. He was in pain. So she was very frustrated with the other members of the medical community. Even one of the eye doctors who said it's difficult because the eye doctor keeps asking them rapid questions, and she's looking at him like, why are you even trying to answer you? Talk to me. So even he was in the process of medical community still having some issues.
Okay, thanks for sharing that. And again, it's very tough in terms of when it comes to decision making in someone with dementia. This was one extreme example, but I was hoping it was an extreme example, but I'm pretty sure it happens quite often where when patients and families with dementia navigate the health system at different points, they have varied experience in terms of how comfortable providers are with treating someone with dementia. And it takes and people can be at both extremes, where on the one extreme we say, okay, they are still decisional completely and they can voice all their needs and we'll listen to that. Or on the other extreme, where we would say they have no decisional capacity, they cannot make their own decisions. So I think we need to find a balance in the middle where we can do some common sense things as we go forward. So unfortunately, the disease, it's a continuum. And depending on when we catch these patients, their capacity to make decisions vary very widely. And we see this problem a lot in the hospital, where we would have consults several times as to, is this patient capable of making their own decision? Sorry today, quite often that comes about when someone refuses to do something that the doctor would want to put them through. But we welcome these consults as we try to put our 2 cents in. Now, there are lots of tools available to try to help people figure out if someone is capable of making decisions, and that's something physicians can do with some training. I'm not going to go into details about that at this point in time, just to raise up the issue that decision making would be a big issue, and if we don't catch this early on in the disease process, and we'll talk about trying to make sure we have someone appointed legally that would be able to help make decisions as time goes on. Now, talking about dementia, dementia, like any other disease, can influence another disease that's going on in our body. So it's very rare to find a patient whose only problem is memory. And as we live longer, we are noticing that people are burdened with more than one disease at the same time. And this phenomena of multimorbidity is a big area of research unto itself. And it's a fairly early field of research. And now, dementia, some of the features that go with it, people being, sometimes even not being diagnosed with dementia, that still happens. And usually it's very common for people to go through 7 or 8 specialists before they get a diagnosis of dementia. And the forgetfulness over time can lead to problems with following instructions or taking medicines properly. Now, this is something I'll have to inject, that even patients without dementia, they have a hard time taking medicines properly. I mean, they're tough. I can tell you, even when I had to take a course of antibiotic for something, I don't think I finished it completely, sad to say. But I could sympathize very well with someone who has to take more than one medicine at the proper times. In fact, Dr. Cynthia Boyd, wrote a very good article where she talks about some of the burdens associated with guideline-driven treatments, where we have good guidelines telling us what to do when someone has diabetes or high blood pressure, but we don't have guidelines to help us when somebody has dementia, has another illness, and how that interferes with that. So hopefully that's something that's going to change over time. They are just starting to make efforts to work on that. But the reason I put so much information up front about how difficult it is with a patient with memory issues is they may have questions very often. It's very common for me to be in the exam room and the patient might ask the same question 4 different times before they leave. And I could sit and explain the same thing over and over again, but they might seem very happy at the moment, but they might forget and ask me the same thing. Now, I can deal with that in the office when I'm there, spending 15 minutes, maybe 30 minutes, but definitely it takes a big toll on the family as they don't know where to escape. They're there all the time. And so when they come to the office and when I find out, okay, they're not taking a blood pressure medicine or whatever. So I could be like the doctor and say, you know what, controlling your blood pressure is really important. Why are you not doing your job? Why are you not, getting the patient to take this medicine? But that doesn't lead to very good outcomes from my experience, because family members, they're doing their best to try to help and struggle with them and try to get them dressed. And in some ways, we almost regress to an earlier point in our life. Just like when you have trouble raising kids, getting them to do stuff and fighting with them to take their medicine, it may come to a point like that at some point as the disease progresses. So we need to keep that in mind as providers when we come up with plans. And so the monitoring aspects could be very stressful. In fact, when you calculate if somebody were to do exactly what they're supposed to do, even for 2 or 3 medical conditions, let's say they have diabetes and high blood pressure, it takes an inordinate amount of time, all the time, constantly, every day. And it's not necessarily very practical. And I'll have a link to that slide a little later in the talk. And so we need to keep that in mind as we come up with what to do for our patients. Now, this video, I'm going to show just a brief portion of it. It's going to talk about a virtual experience for people to experience what a patient with dementia might go through or what it feels like to them.
QVAR is an asthma controller made with small particles of medicine. Small particles of medicine designed.
More than 5 million Americans live with Alzheimer's disease. It's a long, hard road, not just for those who suffer from the disease, but also for the caregivers, children tasked with caring for an increasingly dependent parent. 4 years ago, ABC had the chance to put cameras inside a Texas home as a couple took on this terrible challenge, and my co-anchor Cynthia McFadden has followed the family ever since. Cynthia?
Terry, one of the things we've learned over these years is just how little most of us really understand about the disease itself. I thought I knew a lot about Alzheimer's, but after Blaine and I took part in an experiment simulating what it's like to have the disease, I found out I didn't. It was 12 minutes that changed my life.
Blaine Wilson's mother, LaWanda, came to live with him 4 years ago. He'd just married his new wife, Georgia, 5 weeks earlier. Blaine soon learned it was much harder than he thought.
Oh, God. Wait! She's going to drop her car.
And later, she did. She lit fires. She wandered off. But LaWanda doesn't look sick, and she often seems fine, which makes it hard for Blaine and Georgia to understand how limited she really is. And that leads to frustration and resentment.
Just tell her to wash his clothes. I'm trying to wash it. I can tell her that she knows what to do. Are you afraid? I mean...
No, I'm not afraid. You know, I mean, it's my mother. You don't understand.
The more we watched the tapes, the more it became apparent how little Blaine and Georgia really understood what was happening to LaWanda's mind.
Do you really feel you understand the world your mother now lives in?
No.
What's going on in her head, her brain?
I have no idea. I have no idea. I need to understand that. I need to know what it's like.
So I told Blaine about an experiment developed by P.K. Bevel and administered by her colleague, Lori Labershak. The experiment helps families and caregivers actually experience what it's like to have Alzheimer's.
I understand it's a pretty rough experience.
It needs to be experienced. It'll help me to understand. I would love to.
I agreed to undergo the experiment with him.
Could you have a seat, please?
Our journey into another world begins here, in this bedroom, where Blaine and I are suited up with some deceptively harmless-looking devices. Goggles simulating macular degeneration, glaucoma, and cataracts, conditions that older people with Alzheimer's often have. Likewise, latex gloves are placed on our hands, and our fingers are taped to make our hands feel arthritic, clumsy, hard to bend.
Remove your shoes.
A substance is placed inside our shoes to make it harder for us to walk.
Ooh, that is uncomfortable.
And on our heads they place earphones, which emit an incessant jabbering, a clamor of noise that some Alzheimer's patients say is constant.
Individuals with dementia say, we're hearing all this stuff, and they can't turn it off.
Then we're each given 5 tasks to perform, and only 12 minutes to accomplish them.
I'd like you to find the tie and put it on.
I can't hear you.
Blaine has a hard time concentrating from the start.
Your time begins now.
As he enters, Blaine is immediately disoriented. He staggers, reminding us of the way his mother looked on our tapes. Blaine tries to accomplish his first task, clearing the dishes off the table. But when he goes to put them away, he can't find the kitchen. So he gives up. Blaine finally finds the kitchen, but he can't remember why he's there. And again, the similarities to his mother were astounding.
She'd open cats, and then she would shut. Mother, what are you doing? Nothing.
But Blaine is doing a lot better than I am.
What the heck is this?
It's only about 2 minutes into the experiment, and the noise from the headset is driving me crazy.
God! So annoying!
As I try to accomplish my first task, find a white sweater, I work myself into a frenzy.
White sweater.
Remember, what I'm hearing is this. And believe me, it drives everything else out of your head.
Annoyed!
This is tough. I felt confused, kind of panicky. If I had to go through very much of that, I just might go crazy.
All right, that's not a sweater. That's not a white sweater.
When you do understand why people start talking to themselves.
This is not a white sweater.
I was trying to organize my mind by saying, okay.
Okay. All right. Not a white sweater. Not there. I don't know about that.
You're doing great.
PK was in the room, and at one point when I sat down in frustration on the sofa, and she said, "You're doing great."
Why don't you start with finishing setting the table?
And she told me what else I was supposed to do. I'll remember that.
The reinforcement.
Yeah, because you feel so alone, and you feel so frustrated, and there's no, you don't know what you're supposed to do, and it's so dark.
Reluctantly, I go back into the kitchen to try to find the plates.
Glasses. How long have I been doing this? About 20 hours? I'm not doing great. I'm not doing great.
And once again, I get distracted and go looking for that white sweater.
This looks good enough. This is like a... Okay, it's not exactly a sweater. All right, I'll put it on my shoulders.
And I end up looking a little eccentric.
Her son's going to say, Mom, you can't go out like that. You're getting a little off here.
God.
In the meantime, Blaine has moved on to the bedroom, where he's supposed to match 6 pairs of socks.
Hell? I don't know, man.
Instead, he starts folding everything in sight.
I swear, man, this is crazy.
By now, Blaine seems to have forgotten his list of chores. He was supposed to have found this tie, for example, and put it on. Instead, he folds it along with everything else.
Shoot.
It reminded us of the time Blaine's mother set out to cook something for lunch, then got distracted washing dishes, and didn't remember until the pot was burning.
Place!
After 12 excruciating minutes, the experiment was over.
I give up.
Blaine, your time is up.
Huh?
Your time is up.
Oh, shit.
What an unpleasant experience.
Damn.
Yeah.
I couldn't do anything.
Blaine was visible.
I'm going to stop there. It's actually a pretty interesting video and very lengthy, and gives you a newfound appreciation for what some of these patients might be going through. And it's very scary to watch too. And actually, as part of our training for our fellows in our department, we actually arrange for that to go through. And that's something that could be done even for our internal medicine residents or others to get an exposure to some of these concepts. Now, again, all is not doom and gloom. So whenever we do come up with, okay, if we've decided this patient needs this particular medicine and we're going to try to keep them. So getting them to be compliant would be a big issue. And so we may have to get help from technology.
In the earlier stages, we have patients in the family come in and say, we're worried mom's not taking her medicine right. Mom still lives alone, she's fairly good functioning. So there are some things you can do. You can set up your medicine for 14 days, 7 days, however you want to do that. And if she remembers to take it, great. If not, there are some things like the e-pill dispenser. Lifeline has one. If the consumer eats month, you can fill it up, and it will set off an alarm and say it's time to take the medicine, and it spits it out for you. This one just dispenses the pills. The lifeline dispenses a cup, a sealed cup, and if they don't take it in time, it'll move it over to side block, side space, and elder care services in town, the Lifeline and things like that. If they are at later stages, and you're actually giving them the medicine, some tips to do that. One of these videos is Dr. Raj, I think it one. So you can't get over anxiety with them. You know, it's like talking to a tablet sometimes if you are trying to do something with. You have to stay calm. You can't yell. You can't go fast. You have to give them time to process what you're trying to do. If you have to say it again to them and repeat it verbatim, because you're still trying to process the beginning of that sentence. Some things you might try are to give it to them one at a time. The less conversation is better. So it's time to take our pill. Hand it to them one at a time. Don't engage in any other conversation. Like Dr. Raj was saying, you might get all kinds of questions, but if you engage it every time, his entire 30 minutes would be answering that same one question. So give them the pill. They might be saying, why am I taking this? This is stupid. I don't need it. I'm fine. Ignore all that. Just hand them the pill and give them a glass of water until they take it. And then the second pill, however many, they have 10 pills, do the same thing 10 times. If that starts to not work, if the ignoring the demands and you're stupid, I'm stupid, you take it doesn't work, put in applesauce, put it in pudding, put it in ice cream, something palatable and nice and sweet, and do that. Ask the pharmacist if it can be crushed or not. Ask them if it's going to taste really bad if you're going to crush it. If it tastes really bad, you put it in applesauce, it still tastes really bad. So ask them if it tastes bad. If it does, try not to crush that one, because we're going to want to put it back out. But some medicines taste really gnarly. But the important thing is to stay calm. To speak nicely. Ignore the negative, praise the positive. So when they do take it, that's great. How about some ice cream after this? Or have leftover cookie, whatever. Praise the positive, ignore the negative. Because you're going to get a lot of negative. You're going to get a lot of feedback that's not nice. Don't take it personal. Just ignore it, praise the positive.
Thank you. And I see we have 10 more minutes left. I'm going to stay behind and answer more questions if you have any, but we do have some interesting slides too. So I'm going to focus on a few of them that are really important and something you can take home and use it right away today. So when it comes to the impact of chronic disease, that over time also affects somebody's memory status. In fact, things like high blood pressure, diabetes, or even pain that's not well controlled over a long period of time can impact someone's memory. At the same time, we have to remember the balance, because overcorrection of these can also lead to bad things. What do we mean by that? So when you look at, and this is just taking heart disease an example. So this shows as we grow older, the incidence of heart failure increases. And it also shows that when they look at the memory of these patients, the incidence of dementia also increases. Again, it might not be a very simple, okay, they have poor heart function, they're not supplying enough blood to the brain, but there might be more biomolecular things going on beneath the surface. So we don't still have the complete answer on the mechanisms. However, we see that with time, it becomes a problem. And there are plenty of studies which show that early blood pressure control in midlife affects the health of the brain as we grow older. So when somebody has a really high uncontrolled blood pressure when they are in their 40s, that might impact their development of memory problems when they're 60 or 70. What about diabetes? Now, as we look into it more, we are finding out that diabetes can also affect the brain. And this lists some of the mechanisms that might be involved. So what you could find is there's no easy point A to point B. It can take so many different pathways and different mechanisms. And at the end of it, they do show that it can result in death of brain cells. Now, this just for, I was hoping to put it out for our medical students in here because we always like tiny little diagrams, but even here it's difficult to make out all the signaling pathways. But suffice it that there are many different receptor pathways in our body that ultimately can lead to changes in the neurons or the brain cells. Now, people have always asked, okay, can we turn this to our advantage? Are there things we can do to make this better? And now this is a very small letters, you can't really make it out, but a lot of the things so far, and this is a paper from 2010 where there was still not good evidence, even though there were many studies being done, the level of evidence or the quality of it was not the best. So there were lots of limitations. But still, when you look at risk and protective factors, the studies have shown risks such as depression, diabetes, smoking, or a risky genotype of the ApoE allele, E4, can all lead to changes in memory over time. And things that can help, it seemed to be some environmental factors, such as diet. When they looked at a Mediterranean diet or increasing a vegetable intake, improving physical activity and cognitive training, that seemed to help in some studies. And but we always look for randomized control trials when it comes to, okay, do these things truly seem to make a difference? And so there were some small studies kind of looking into that. More recently, they had this study. It's called FINGER. It's done in Finland, and it was done over a 2-year time period involving over 1,000 patients. And they had at least 600 patients in each arm. So the intervention was they included a strenuous activity. I mean, I don't know how they do it in Finland. They were able to do all this. So they were able to give an intervention involving diet, healthy diet, exercise, some form of cognitive training, and then they monitor their vascular risk during that time. And what is surprising or not surprising is what they were able to demonstrate, that even within the short 2 years, if you look at the midpoint was 12 months, and over 24 months, there is a big separation in the, so the control group here is the one in blue, who are doing things the normal way. And when they introduce this lifestyle change in red, you see, and here higher scores are good. So they were doing better than people doing their usual stuff. Now, this is just in 2 years. And so based on this, they've extended the study, and they are going to follow these patients over a 7-year period now. And we can look forward to what that shows. Now, this is something I would leave with the medical doctors, because we have this concept of a J curve. Again, if you look at it, I guess you can make out the J. What it talks about is when you try to plot, in this case, blood pressure. So it shows diastolic blood pressure, which is the bottom number, and the systolic on the top. They both show a similar pattern where seems to be a sweet spot when it comes to blood pressure control, okay? And if people run higher than that, uncontrolled high blood pressure, that can lead to bad outcomes in terms of higher death from stroke or heart disease. However, the interesting thing is when they are lower than a certain number, even then their risk goes up. So because in the past, the guidelines have always left it at, well, you need to control their blood pressure. You need to keep them less than 140 or 90. However, they wouldn't have a bottom number in terms of what is that number. So more recent guidelines, when they come out, at least they're starting to acknowledge that or talk about that. When you look at the literature from the American Geriatric Society, we would even go farther in being a little more lenient with these guidelines. Currently, I think they make a relaxation of about 5 points. However, in a real life patient where we have constant battles with even taking their medications properly, you need to pick and choose what is going to be the individual goal for that particular patient. And so that's really the difficult part. I mean, this data is pretty clear. It shows, okay, this number is good, this number not so good. But any number that doesn't agree with your patient, if they're getting dizzy, if they're lightheaded, then that number might be too high or too low. And so we may have to reassess things. And the same goes for when we look at diabetes too. So the problem is with a lot of these things, until we ask the right questions, we don't get the right answers. And so only now people are becoming more aware of this, and they're spending more research efforts in this area to make sense of that. So I would leave with when it comes to diabetes, because even in somebody with dementia, they remember things that happened before quite well. So I have this conversation quite often as to what is your goal for diabetes at this point in time. You're 80 years old, and you have problems with memory, and now we still need to treat the diabetes. But when you're younger, we choose for very aggressive lowering of blood sugar. So we try to keep it as low as possible without running into problems with low blood sugars. So what happens is, as somebody grows older, we notice that having their blood sugar very, very low or tightly controlled, let's say close to 6 in somebody who's 90 years old, 80 years old, that doesn't necessarily mean it is good for them. Because we always thought what was good for somebody, how we treat somebody in their 40s or 50s is good for even somebody who's in their 80s or 90s. But when we got the data and we look at them, what we find is older adults, they don't do well with very tight blood sugar control. And we don't have a definitive answer for why that is. However, when they look at all-cause mortality, that goes up when we push for really tight blood sugar control. But that doesn't mean we allow them to run really, really high. So we just need to relax the guidelines by a little bit. So what is that? Again, a rule of thumb. Somebody who's about 70, I would probably be okay with a A1C of about 7 or so. 80, maybe about 8. 90, maybe about 8.5 or so. So it doesn't mean if somebody's 100, they can be more than 10 or 11. So within reason. So we are not pushing for them to be less than 6.5, because that would be a really big struggle to get there. And even if we get there, I don't think it's really a good thing based on what we know now. And unfortunately, the guidelines still take time to evolve and develop. So at least they're starting to talk about it. If you look at the literature from the patients in nursing homes, especially now, it's definitely recommended that we don't push for these very aggressive glycemic controls. But again, it's a big battle in terms of your training and where you come from. As an endocrinologist, you might be very focused on that, and you might really push for that. So unless you take care of older adults a lot and you see problems with that, so sometimes it is challenging, even as health professionals, when we try to communicate with one another. Now, I'm going to stop there because it's about an hour. We still have, a few nice videos and stuff. But if you're interested, we can definitely send you links. So I don't want anybody to feel compelled to stay behind, but we are going to be here, and we'll be happy to answer any focused questions or something I can elaborate on. Okay, now that's a very important question. Actually, we would love to have the primary doctors continue to care for the patients, because they are the ones who get to know the patient over a long period of time and their family. But it's true that taking care of them becomes more challenging as time goes on. And also our mindset in terms of what is the right treatment goal for this patient will have to change. So it would be a disaster if the primary doctor wants to treat the patient with the dementia the same way they treat any other adult, or in terms of managing their other illnesses. Because okay. I think the reason I would think about would be it depends on the prognosis, right? So if somebody has 2 months to live, maybe you would treat them a certain way compared to somebody having 20 years to live. So even though this is a terminal diagnosis, meaning at this point in time, we don't have a cure or an intervention that's going to stop the disease, it is important for us to figure out how long they might have. Because like I mentioned earlier, even when we diagnose somebody with Alzheimer's dementia, they could still have upwards of 20 years. And so we might have patients who might still progress slowly over time, who would still need to be treated for their risk for heart disease or diabetes and things like that. So, but however, I would make different decisions as time goes on. If we are having to deal with more complications, or if the quality of life becomes more impaired with all the burdens we put on in terms of trying to fight with them every day to take the medicines. So I would be more open to listening to not just the patient, but also to the family who accompanies them. So if you are taking care of, and the problem is whether you like it or not, when you're in practice, you are going to have to take care of older adults who are going to increasingly have problems with memory, no matter what specialty you're in or primary care. And so we all need to raise our awareness of, do we treat this patient with the same way in terms of our goals for treatment, and also how are we going to get them there? And even if we get them there, let's say a target blood pressure or diabetes goal, does it actually lead to good outcomes? So it's okay to be inquisitive and question that. The one problem I would see with some of these guideline-driven measures is whether we like it or not, they are the ones that are going to be measured, and at some point, and it's already happening, they're going to link how well they measure quality to these measures, and they would also tie payment, reimbursement to these measures. So you might provide excellent care to your patient and do right by them. However, if you don't have the A1C at this level, you're going to be penalized. And unfortunately, I mean, that's something, unless that's more of a systems fix where people higher up need to be aware of this issue and build in some ways to capture the complications associated with this patient. So when somebody with multimorbidity, dementia, along with other illnesses, they need to have a different weightage associated in terms of how they are evaluated. But you bring a good question as to caring for them. I would, as a rule, because patients are very fearful about being abandoned, and families especially. No, that is a very, very good question. So a lot of the screening tests, again, we would have to start talking about stopping them. And usually, some of these things, when you look at it, it makes sense if somebody has a life expectancy into 8 to 10 years or so. And if we are getting to the point where, depending on the stage of the dementia and how functional they are and their other health status, we will have to start talking about, does it make sense to put them through it? So the short answer would be, somebody with a severe dementia, we would not put them through unnecessary testing. And so that's a conversation that needs to be had, preferably even earlier in the disease process, so that the patients can also weigh in or talk about these things. Because quite often when you sit down and have these conversations, it's very difficult for the family member to make a decision, because no matter how much they love them, it's another person, and they feel very guilty about making some of these choices. And the physicians talking to them helps in terms of making them understand, just like any other medical procedure, it comes with good and bad. And right now, the balance of the bad parts are going up. However, when we're able to talk with the patient, quite often when they're able to speak their mind, they end up trying to simplify things. Very often when my conversations with my patients, they are very happy to stop medicines or decrease the pill burden or trying to make their life simpler. And so that's something the guidelines are also a little remiss because they're good at starting things, but even when it comes to mammogram or things like that, it's very based on age and certain cutoffs. It's very rarely, they come up with very clear-cut things. So with mammograms, for instance, even, okay, when somebody's 75 or so, let's stop doing them. However, we always have special populations or people with very unique and individual concerns where we would still say, you know what, even at this point in time, maybe we will check this. But that's where the science and the art of medicine needs to find that balance. And no matter what, I mean, that's one of the reasons as time goes on, we would still have our job in terms of helping our patients navigate this as time goes on.
But I also think that speaks to the importance of having a clear discriminating conversation early and both listening early with the patient, the family, and the doctor, so that they can review the entire medical history, look at any comorbidities that may be there along with the diagnosis of dementia, and talk about how aggressive or how palliative they may be in their care. There's a form called a MOST form that Kentucky's working on getting through legislation to be adopted orders. Some facilities, if there's anybody who's worked in a facility, uses it as a pulse form of physician's order. Hospice uses it. It's a good form to start a conversation, and it's a good form to fill out. It talks about whether you want to be a DNR or not. It talks about how aggressive you want to be in your medical decisions. It talks about antibiotic use. It talks about feeding tube, IV therapy, IV fluids. It tells you all of that. So it's a good conversation starter. It's a good guide for the conversation. And we have it at our office. We can do it for you, or as a hospice uses them. Facilities, there's several facilities in town, nursing home facilities that use them. But it's a good tool. And using that as early as possible to get that conversation done, so that later in the process, you're not stuck trying to make those decisions for someone else.
Right. And that's a very difficult question to address, because when it comes to quality of life, what is quality of life? I mean, it's very hard for, even as a physician, for me to make that determination, because what my values and judgment of what is the quality of life for me could be very, very different from what my mom feels about it. And when it comes to my patients and their families, so the biggest thing would be taking the time to sit down and talk about what that means for that person, or if they are not able to voice that, talking with the family to get a sense of, again, the way I would frame that conversation would be if their loved one was able to be, in that meeting and able to voice their mind, knowing everything that's going on, what kind of choices would they want to make? So try to put the burden on how the patient would make decisions, rather than asking the family, okay, does this mean quality of life or not? Again, it might seem semantic or in terms of phrasing, but I think that also helps a whole lot in trying to, because the families might then start thinking about, okay, to me it doesn't make sense, or but if it was up to me, I would continue to do these things to try to treat or extend life. But there might be others who might say, you know what, but as a person, even though he's alive, or this is not the essence of what he is, and we are maybe buying more time, but at what cost? So families come up with very different, for the same situation, some people might say, okay, this is terrible, we don't want to, do more things to prolong life in this way. While others might say, you know what, even now, it's okay, they still laugh at me, they don't know who I am, but they know I'm a friendly face, and we play a, maybe watch something together. I mean, it could be very tiny things, but so that's where, we'll have to teasing out, what aspects are still enjoyable or is quality for them. And then when we talk about treatments, unfortunately, even though, we have several medicines available for Alzheimer's dementia, none of them, I mean, we don't know the underlying cause still in terms of, because we've developed treatments to interrupt in different paths of the amyloid beta aggregation. However, those treatments haven't worked out yet in the studies, or they've worked out too well and the body starts attacking our own brain, and we've had problems with that and had to stop some of those trials. The current medicines we have, they are more addressing the symptoms in terms of trying to alter the certain chemicals in the brain. So they don't necessarily fix the disease or treat it. They seem to buy us a little bit more time. But again, a lot of these drug studies, in order to get the approval, they study it for a period of 6 months or so to demonstrate, okay, there's a difference between these curves. So we don't necessarily have long-term studies to show that they necessarily work over many, many years. But then the drug companies are also very good at marketing these things and also pointing out some fearful information. So they have one small study where they talk about, okay, when we stop this particular medicine that the patient is taking for dementia, they have this decline in their memory, and even when we restart it afterwards, they're not bouncing back to what they were before. And however, so when we look at the data as a whole, there are other studies which show even when we stop these medicines, that doesn't necessarily happen. But then when I talk to my patients on these medicines, and at some point we are dealing with side effects from the medicine. So these medicines are not benign. People can still have problems with the stomach upset or GI symptoms that could be very bothersome, or sometimes even problems with low heart rate, among other things. And in some patients, they are more sensitive. Medicines produce the opposite effect of what we are trying to use them for. So people might have more behavioral symptoms at times as a result of these medicines. And so at different points in time, we might make the decision, okay, this medicine needs to come off, but then we have this conversation, and I'd be very surprised, but drug companies are very effective at marketing or getting their message out, because quite often my patients or families they've done their research, and they're worried that, okay, how do you know what's going to happen if we stop this? But the problem is it's very difficult to prove a negative. So when you take a medicine, that doesn't necessarily cure it, but we still expect the disease to slowly worsen over time and the patient declines. It's hard for us to argue, okay, if you are not taking the medicine, your decline is going to be much steeper that's been a challenge in this particular illness, because with or without the medicines, patients do decline over time, but the rate, we are hoping to slow down for a short amount of time that we know. And unless we have more data, we cannot say, that's true over a long period of time. But unfortunately, that's where our patients end up on these. And again, if you look at the drug studies quite often, even though they have big numbers, it's looking at your patient is your patient. They won't fit the profile of the drug studies, because in order to study these drugs, they try to pick very clean patients with only their illness and try to avoid any other illness, so they won't have any kidney problems, heart problems, nothing. But when you look at the real world patient, they won't fit the study criteria. They have more than one issue going on, and we are trying to figure out the balance between different things. So there's a lot of moving parts. And but the bottom line is these medicines work up to a certain point. But once we're dealing with more severe stages of the dementia, and we are at a point where they've already had to move into a nursing home, because the point of some of these medicines is to try to keep them at their home as long as possible. But when they have to move to a more higher level of care, then we may have to reevaluate if this medicine is still needed or not. And so unfortunately, we don't end up being able to stop these medicines unless they clearly have some side effects from it. And these medicines are also expensive, so sometimes patients or families might make decisions based on that. And also, the other thing is sometimes I find that people end up on more than one of these medicines. And even though the data is very slim on the benefits of that, so I would try to, in my patients, simplify, make sure we at least cut back to one medicine, and over time try to stop it as they go into more severe stages. And quite often people, even when we do that, we don't notice a very dramatic difference. And in fact, sometimes they notice better things of something. That's something we see quite often in palliative medicine, where towards the end of life, we try to simplify things. We stop a whole bunch of medicines. And surprisingly, what happens when somebody's taking 9 or 10 different pills for all kinds of different illnesses, quite often the pills end up causing more trouble. And they're on more pills to counteract the side effects of another medicine. And so people end up actually feeling a lot better or living longer than we expected when we actually simplify medicines rather than having a shortened lifespan. Okay. All right. I appreciate your patience. And if you do need a copy of the presentation or any particular article or parts of it in general, you can leave your number, name, and or email Anne about it, and she'll hunt me down.